So hello, everybody, and thank you very much for joining us this evening. Today, we're going to switch gears a bit. We're going to go into facial plastic surgery, and we have with us Dr. Walid Izzat. Dr. Walid, can you hear me?
Yes, I can hear you. Good morning, or
Morning.
good evening for you, I guess.
It's about 5 o'clock here. What is it in Boston?
It's 9 a.m.
9 a.m. Good. Well, great to have you with us. Thank you very much for giving us the time.
Oh, thank you for having me.
Thank you. So Dr. Izzat is going to talk about managing saddle nose deformity, and we already have like 95 people. We get like, by the end, we get about 300. So thank you, Dr. Izzat, and please, you have the podium. Go ahead.
Okay, I'm going to go ahead and share my screen if that's okay.
Sure, please go ahead.
And we'll go ahead and start. Can everyone, is it coming through?
Absolutely.
Excellent. Okay, so thank you for having me on this. I think this is a wonderful program. I was completely unaware until I received an invite and looked it up, and I just was. I think it's a wonderful use of technology and education, and I sincerely hope that for the Academy here in the United States, you guys present your use of Academy and it's a success. I think it's a good story that should be shared. My name is Walid Izzat. I'm director of the Division of Facial Plastic and Reconstructive Surgery at Boston University School of Medicine. The saddle nose, I've been asked to talk to you about the saddle nose deformity. This is a subject that has been sort of an interest of mine since I was a resident when I wrote my first manuscript on it. And it's interesting how it sort of came about in practice because I was initially hired with a focus on microvascular reconstructive surgery. And a lot of the saddle noses from people in our hospital were actually referred to our department. No one really knew what to do with them. So they sort of fell in my lap, and I got a chance to take the manuscript that I had written and put it into practice. And now, 10 years later, my practice has evolved to about 70 to 80% rhinoplasty. While the vast majority now is cosmetic, I still have a significant interest in reconstructive rhinoplasty. So for those of you who are still in training on this shared, you'd be surprised what a project that you're attending gives you, what it leads to later on in life. So don't miss out on any opportunities. I have no financial disclosures. I'm going to start with a quote from Bertillon. He was a French anthropologist in the 19th century. And it says, "The nose is the organ that, more than any other in man, gives the face its peculiar character." This is a quote that I like to start off with because it highlights the essential role the nose plays. It occupies a central third of the face. And whether or not we are focusing on someone's nose, subconsciously, it is a large part of our perception of the face. And because of that, it is a significant contributor to facial aesthetics, but also to function. Let's talk briefly, set the sort of the stage for our talk by talking about the structural support of the nose. The nose is very unique. It's one of the few structures in the body where every type of tissue component plays a significant role, from bone, cartilage, fibrous tissue, the soft tissue, skin envelope, and the mucoperichondrium. The base of this support is actually the middle vault. And it's a bony framework that starts with the bony septum, the nasal spine, the nasal bones, and this is sort of the basement foundation for our support structures to the rest of the nose. The septal cartilage is the single support wall, and I usually refer, when I discuss with my patients the role of the septum, the analogy I like to use is that of a Native American teepee, where a central pole holds up the entire structure. And the shape and tension on the sides can be changed simply by either raising or lowering that central support. Now the septum is bound, as you know, to the bony cartilage as well as the nasal spine. And from there, its contributions are omnipresent throughout the entire nose. It supports the middle vault through the articulation with the upper lateral cartilages. But more importantly, the role in nasal tip support is pretty significant. And I feel like it gets a little less, its contributions is a little less significant. So if you look at Tardy's tip support mechanisms, there are major contributions and minor contributions. And if you look at the difference between the major contributions, the minor contributions, the one thing that stands out is with a major contribution to the mediocrural attachments, as well as the membranous septum and the cartilaginous dorsum. I don't know why this is going up. Sorry about that. It's going a little fast. But it really highlights the importance and the contribution the septum plays to all portions of the nose, both for aesthetics and in function. Functionally, the nasal valves are all highly dependent on the structural integrity of the septum. So as you know, the internal nasal valve is basically the upper lateral cartilage, the septum, and the head of the inferior turbinate. And this accounts for the vast majority of the nasal resistance while we're breathing. And obviously, the entire 50%, medial 50% of that nasal valve is solely related to the septum. And even the external nasal valve is highly dependent on the contribution of the septum to the support of the medial crura of the tip. And this highlights not only the aesthetic component to the septum, but also the functional component. So what is the saddle nose deformity? The cursor is visible, correct?
Yes.
Yes, excellent. So the saddle nose deformity occurs when you have a loss of septal support for any reason. And there's a number of reasons why this can happen. We'll go into that a little bit later. But what happens is you lose a significant, you lose structural integrity of the central support wall. Now, initially, you get that classic saddle depression where the middle third is depressed. But as this progresses, and this is very important to understand for addressing it, is that as this progresses, you're going to start to see changes to the support mechanisms of the tip. So the tip will deproject, it will start to over-rotate and contract, same with the columella. You can already see how you have a loss of function to the internal and external nasal valves. And this support mechanism is so strong that in the most severe cases of a saddle nose deformity, you will start to see contributions and deficits in bony projection as well along the rhinium. This results in also not only the classic appearance of the saddle nose deformity from a lateral view, but also anteriorly, this is where you blunt the lateral aesthetic lines of the nose. And get that blunting across it. It's like a very, very wide inverted V deformity, but it's not an inverted V deformity, but it's blunting of the lateral lines. But it essentially breaks up the aesthetic lines from the anterior view. Now, this is not a new phenomenon. This has been present for and actually been described since the time of the ancient Egyptians. And I'm pretty proud of that because I'm Egyptian. So that's sort of a little shout out to my fellow countrymen. But before the antibiotic era, the most common etiology of a saddle nose deformity was infectious. So you had syphilis, leprosy, an abscess that formed, and then trauma and other forms of disease processes that has a predilection for cartilage was present. In the present day, post-antibiotic era, this tends to be more of an iatrogenic cause. So prior septorhinoplasty, traumatic injury to the nose, perforation from either intranasal drug use, GPA plays a role. And the infectious etiology has gone down significantly. So even though it's pretty rare to have an infectious etiology nowadays, especially with the vast number of specialties that we work with in treating nasal conditions, this still is present. Before going into classifying and treatment, I want to talk about the reconstructive materials that could be used. And I want you to know that I'm a little biased in terms of reconstructive materials. I'm an autograft guy. I understand there are numerous reconstructive materials to be used. I'm going to speak about my preferences, why I've arrived at these conclusions. Obviously, there are some surgeons in their hands prefer to use other materials. So this is sort of my perspective on the issue. Alloplastic grafts have been in use for quite some time. Probably the most common alloplastic graft that I see in my practice is silicone. It's a great implant material. It's inert in terms of its biologic properties, and it heals really well within the body. It forms a fibrous capsule around the implant. So, the implant doesn't necessarily integrate into the tissue, it allows for ease of removal. Now, there are some studies out there that show a large number of patients that have been augmented in the nose. It's very attractive because it's very quick. I mean, they used to call it, I'm sure they still call it the lunchtime rhinoplasty in Asia, because all you need to do is create a pocket and then put dorsal augmentation with an alloplastic graft. But when you look at these studies, the follow-up can vary, can be fairly short. Implant failure for this study was 7.8%, and that was at 4 months. Longer term studies and newer studies have shown that the failure rates for these implants are anywhere between 10 and 15% on a systematic review of the literature performed by Dr. Ishii this was done from Hopkins. The high infection rates. And it's really thought that it's due to calcifications that form around the fibrous capsule that sort of rob it of its inert biologic properties, and it's viewed as a foreign body, even when it's used in conjunction with some autografts. Other alloplastic grafts that have been described for saddle nose deformity reconstruction, Gore-Tex. Gore-Tex, again, is also biologically inert. It integrates a little bit more heavily into the tissue. And it's not very rigid. So this is really ideally used for nasal dorsum camouflage. MedPore has gained a lot of notoriety in the past, 5-6 years for nasal implant use. It's used widely. The beauty of MedPore is that it allows tissue ingrowth. So it resists long-term extrusion. And it provides good results in the short term. It is susceptible to implant fracture. I do have quite a few patients in Asia who have I have had to revise due to fractured implants. The implant itself is not much of an issue, but when it is failing, it becomes an issue just because the sheer amount of dissection of the soft tissues that are required in order to take this out presents an additional challenge in revision cases. But they're attractive. Because they're alloplastic, they can be manufactured in a variety of different shapes and sizes. You avoid a second donor site morbidity by not having to harvest cartilage. Because of that, it is a very attractive option, particularly those who are operating out of surgery centers where maybe rib cartilage is not a preferred technique within those surgical facilities. So things that have swayed me over the years against this is silicone implant. Again, I have quite a few patients from Asia where silicone implantation has failed. And again, once it fails, it becomes a two-pronged issue. Not only do you have to reconstruct the structural support of the nose, but it becomes a soft tissue problem as well. And this patient actually I removed her implant in the office under local. And this is how easy it is, which is the great thing about silicone, is that removing it's very easy. Most of the time there's a fibrous capsule, so you just kind of pull it out. There's no tissue connectivity, and it happens fairly easily. Another patient of mine, again, the silicone extrusion, saw a few doctors with pain and drainage. It was very small. Actually, this is a subsequent picture. It was much larger as she came closer to surgery, but you can see the implant beginning to fail. And again, I got halfway in and saw the fibrous capsule, nicked it, and it came out very easily. This was one of my first cases, actually. And so I just carved a rib cartilage piece to mirror, because she wanted the exact same appearance. She had it 20 years ago, did not want to change a thing, and inserted it into the fibrous capsule. I don't do this routinely. I don't advocate for this. This just happened to be in her case. And this is a 2-year follow-up picture showing that not a significant change from what she had was and that's what she wanted. But I rely more on the techniques that I use for saddle nose reconstruction. And this is why this topic is extremely important, because once you reconstruct a saddle nose deformity, cosmetic revision rhinoplasty doesn't seem as daunting as one might think. My first, this is a case from fellowship at UCLA, and this was the addition, this is the nidus case that turned me off from MedPour. I've since had numerous experiences, and they've all been the same. And basically, you can see the MedPour beginning to fail, and it's always, it's rare that it's a late failure. I'm not going to say it's a 20% failure rate. The problem is when it fails, it's a big issue. And you can see the implant beginning to extrude. This is the implant, intra-op picture of the implant after we took it out. And you can see the porous nature of the implant. But as we get further in it, you lose those pores. And what that is that's the deeper layers of the SMAS and the skin, the soft tissue envelope that needed to be cut in order to remove this implant. Now, when you do this, you sort of invite a secondary cause of scarring within the nose that is not as predictable as the bone and the cartilage, and makes the case much more difficult. So I will not use any implant material in the nose. And you can see the significant saddling that occurred. I mean, these implants can, because of their rigidity, can provide a significant amount of structural support to the nose. But again, I prefer autologous tissue. I do have quite a few colleagues here in the US that rely on homografts. For those who are unfamiliar with homograft, it's procured from a cadaveric source. It's irradiated to provide sterility. This does avoid a donor site. That's for the cartilage. The alloderm portion, I don't use within the nose. I still see patients who recently had rhinoplasty with alloderm use. Again, I only use autologous stuff. I believe the alloderm sort of has a variable rate of resorption, so it's very difficult to get an adequate contouring. But the irradiated rib cartilage is definitely an option. As much as I'm an autograft guy, the irradiated rib cartilage, studies have shown that it's that the rates of resorption aren't significantly different from autografts. So this is a very viable option. It's expensive, but it's a very viable option. Why I like autografts? It is complete tissue immunogenicity. It does have the lowest rates of complication. And there are a significant number of places you can take cartilage to reconstruct the nose. And it's sort of my mantra that if I can't find tissue to take to your body to reconstruct the nose, that's God telling me not to operate. And so this is sort of my limiting factor so that I don't get myself into trouble. Now the septum, I'm going to not talk about the septum because in the saddle nose deformity, that's the problem. And so most of the time, if you don't have adequate septum, that's not going to be a choice to use for autograft harvesting. Conchal cartilage plays a role in the saddle nose deformity. I use an anterior approach, as you can see here. I find it a little bit easier to grab the cartilage that I need. The incision is readily closed, and when it's in the junction between the conchal system and the antihelical strut, the cosmetic outcomes are excellent. You do have to maintain the antihelical rigidity. This provides the shape to the ear, so if you end up taking some of this cartilage, you will have changes in the shape of the ear. In 10 years and thousands of cases, I have not seen a ear deformity from conchal cartilage harvest, and it's a very low donor site morbidity. Rib is sort of the workhorse for the saddle nose reconstruction. It's very versatile, and there's an adequate stock. It does have a distant donor site. There are reports of excessive or increased postoperative pain, and there have been many techniques utilized to diminish this postoperative pain, such as the paintball, a liposomal Marcaine solution with a longer half-life. To be honest with you, I do this in my outpatient procedures. Initially, I used to stick a drain in. Then I realized that wasn't necessary. You know, for sake of being thorough, I do get a chest x-ray afterwards. I have never incurred a pneumothorax. So I'm actually beginning to question that. As far as post-operative pain when closed appropriately, I usually just inject some Marcaine and send them home. And usually they complain more about either the rhinoplasty or the fascial donor site when I take temporalis fascia than they do for the rib. One thing that you do sort of have to keep in mind with older patients, there is a risk of ossification of the ribs. Some have advocated a limited CT thorax. I won't go that far. I do keep bone cutting and bone contouring instrumentation, including powered instrumentation, in the room when I do these cases, in case I come across an ossified rib, and will utilize an osteocartilaginous graft. I follow Marin and Gunter's description on how they do it. I find this is the easiest and most reproducible way to harvest a rib. I usually target 5, 6, or 7. I don't go for any of the floating ribs. The reason why I do this is the vast majority of my patients are women. It's easy to hide the incision in the inframammary crease. And basically, it's pretty straightforward. You dissect down onto the rib itself. With cautery, I will incise the perichondrium and then continue a strict subperichondrial dissection. This protects the backside of the rib. So it at least in my opinion, virtually eliminates the possibility, as long as you maintain strict control of the plane possibility of a pneumothorax. I attribute his technique to the reason why I haven't encountered this problem. It also maintains a connection for the lateral aspect, the lateralmost aspect of the rib harvest, and the bony rib and the sternum. So it reduces the incidence of flaring of the rib afterwards, which some people are worried about. There are some studies that show that the perichondrium, once it's left in place, retains its ability to produce additional cartilage. I don't think that's ever been proven. It's more of a floating theory. And then the nice thing about it is I use a Doyen elevator once I have it fully dissected to protect the back of the rib, incise directly on it, and then harvest the rib. And usually, and I can't really think of very many instances where this has been violated. And the time that I've noticed, if I've had a resident elevate the rib, if there is a rent in there, because you're so superficial, it hasn't caused any issues. And again, some people bank the cartilage behind the ear. for those parts of the rib that haven't been utilized. Most of the time when I'm taking rib, I end up utilizing most of the rib, so I find no reason to do that. It's really up to you. When we talk about warping and resorption of the rib, there really, again, like I said, there's no significant difference between that. The only difference that was noted was that in irradiated cartilage, there is a tendency to warp a little bit more when the grafts are harvested from the peripheral portions of the rib cartilage. So I think it's obviously there's always going to be a risk of warping when you use costal cartilage, but I think your carving techniques play the greatest role in reducing that risk to a very, very, very low percentage. And the reason is that the fibrous outer portion exerts a lot of pressure onto the central core. So if it's not concentrically harvested, I think you're going to run into problems with warpage. Homografts do have a higher resorption rate in some studies, but it's dependent on the area of the face. Some have gone even lower than what I have listed here of 3.3%. Again, it's probably not statistically significant. The reason why I choose to do the autograft is mainly because if it were my nose and I knew there was a 0.5% chance of warping versus a 3% chance of warping, and I'm going in for what is essentially an elective procedure, I'm always going to choose the lower percentage. So if I would do that for myself, then I would be more than happy to do that for my patients. The other most common, the other common site that I utilize is calvario bone graft, especially in saddle nose deformities and specific instances, which we'll talk about a little bit later. This requires a minimal blood supply. The donor site is very easy to camouflage. The thinning of the hair and baldness are relative contraindications. Again, I've done this on patients who had a very thin hair stock in the scalp or were bald, and I didn't have any issue. The only difference is that the feel and the shape can be a little bit more rigid. To be honest with you, the way I reconstruct my noses, I tend to over reinforce them. So I let my patients know ahead of time that it's going to be extremely rigid. So I haven't seen a significant difference between that and autologous rib. The iliac crest has been utilized, especially in trauma cases. Again, I'm not a big fan of iliac crest just because the donor site morbidity is so significant in terms of pain. If I have to worry about the peritoneum while I'm harvesting a donor site, I'm not a happy camper, so I avoid this as much as possible. So getting on to the saddle nose deformity itself, the initial classification was brought on by Seltzer in 1949, and it was basically a going, gone type phenomenon. So there were three types, where depression of the middle vault without loss of structural support, a type 2 where the loss of structural support was present but no change in nasal length, and 3 when it was a severe saddle nose deformity. And I think this was a great start. But more recently, the quicker you can simplify something, the easier it is for you to approach the problem and adequately address it. And so I rely more on Roland Daniels' classification that came out in 2006. It's a little bit more detailed, but what I like about it is that your reconstructive plan is developed while you're clinically examining the patient, and it makes it so much easier to approach it. And basically there are 6 types. There's a type 0 and a type 1 who's somewhat similar. But as you can see, as you progress with your saddle nose deformity, your reconstructive algorithm follows suit. And to give you an idea of what we talked about, so the septum's contribution, This schematic, this is from Roland Daniels' paper, his description. As the saddle nose depresses, you can see how it affects not just the middle vault, but projection and rotation of the tip, as well as contracture, as well as the bony component contributing to the dorsum along the rhinium. So the type 0 saddle nose deformity is referred to as the pseudo saddle. This is an absolute depression, okay? It produces a relative depression according to the tip. This is most always iatrogenic. So basically someone with a saddle nose or who had a rhinoplasty perhaps made a little, had a little over-aggressive resection of the dorsum. And so there is a relative depression to the tip projection point. And the key to that is that the tip support test is positive. In other words, you push down on the tip, there's a significant amount of resistance to show that the tip is not going anywhere. And this is a patient of mine who had a rhinoplasty with a pseudo saddle sort of appearance, where an over resection of the dorsum. The key to this and the type 1, which we'll talk about next, is that there are no functional defects. This is more of a cosmetic defect. A type 2 or a minor saddle nose deformity, again, it's a super tip depression. It's a little bit more excessive. But here's where you start seeing either columellar retraction, but more importantly, this is where the internal nasal valves now begin to become involved. So at this point, I see a saddle nose deformity, maybe a little bit of retraction at the tip, not always, but more importantly, the modified caudal maneuver in my office is positive. They're complaining of nasal obstruction, and this relieves it. And that's a very important point when looking and trying to address the internal nasal valve, is that you know, the modified caudal, you perform a modified caudal excessively on anyone, they're going to breathe better. The idea is they're complaining it, and you are able to subtly change the upper lateral cartilages and make a big difference in their nasal obstruction. And so this is very operator dependent. The key to this, the type 1 and type 0, is the septal support is compromised, but it's stable. In other words, this is not a process that's going to continue to progress. This is in other words, if a patient has GPA, or if a patient has some form of autoimmune disorder that's compromising the septum, you can sort of expect this to progress if it's untreated. Whereas the type 0 and type 1 saddle nose deformities are more of an iatrogenic cause. In other words, the septum has been over resected. The remainder of the septum's intact. I don't expect this. If I leave this patient alone for the next few years, it's going to look the same. Again, another patient of mine who had a rhinoplasty at an outside facility, over resected, and you can see this relative depression to the tip. The tip is fine. Now, what classified this different from a type 1 from a type 0 is that she also had nasal obstruction that responded to a modified caudal. So this is sort of my physical exam findings guiding my reconstruction algorithm. Type 2 saddle nose deformities, at this point, your cartilaginous vault collapse in the middle vault is fairly significant, but this is where you start to see a loss of tip support. So you see a relative depression, you push on the tip, and the tip's just giving way. So the tip support test would be negative at this point. You have internal nasal valve collapse, and definitively at this stage, you will almost always see columellar retraction. And so this is a moderate saddle nose deformity. This is from repetitive trauma. Unfortunately, she was abused as a child and hit multiple times in the nose, developed a type 1 saddle nose deformity. You can see the clear saddle nose depression. You can see that the tip support, well, you can't see the tip support negative because it's obviously that's a dynamic exam. You can see though there's a significant columellar retraction. She had compromise of her airway from the intranasal valves and a depressed projection point of the tip. The type 3 saddle nose classification is a major saddle nose deformity. At this point, you see a very significant to complete loss of septal support. This flattens your nasal profile on anterior view. And not only are your internal nasal valves compromised, but so are your external nasal valves. So the compromise to the septum is so significant that your external nasal valves are now compromised. And so basically a progression of what we talked about. You do get a little bit of upward rotation and contraction of the tip, as well as contraction of the columella, deprojection of both the middle and lower 1/3 of the nose. And you can see here for this patient, again, type 3 saddle nose deformity. You can't see intranasally, but a complete loss of the septum. This was due to intranasal cocaine use over many years. She has a flattened anterior view with loss of the aesthetic lines, the lateral aesthetic lines of the nose. When this becomes severe enough where the loss of the external, internal nasal valves, the middle third, the lower third begin to contract and rotate, and the upper third begins to lose its height, this is what qualifies as a type 4 saddle nose deformity. This is a very difficult saddle nose deformity to correct. Simply, the big thing here is that the nasal lining, there's severe contracture. So a lot of times you're going to find these patients requiring composite grafts in order to lengthen the nose and derotate it, which can be very difficult to do. A lot of times these patients, due to the loss of bony height, I will start using calvario bone as my go-to over rib, simply because of the amount of bony dorsal height that I have to replace. I won't talk about the type 5 catastrophic. This is a total nasal loss. This usually occurs, I see this more commonly in my practice in patients with large cancers of the nose that had a near total resection. This is more of a large nasal reconstruction, paramedian forehead flap. You're now approaching the time when you would consider a fasciocutaneous, a fascial vascularized graft through microvascular techniques to reconstruct the lining. So we're gonna sort of not touch on this as much because these aren't always seen in most practices. I already talked about that. So I rely on autografts. So for type 0 and type 1 deformities, now that my clinical exam has given me an idea of what I need to do, okay, and I know that this process is static. I don't expect the saddle to progress. The goal is to restore dorsal profile. Because the septal stalk is adequate, maybe a little over resected on the dorsum, but the remainder of it's okay, I can do camouflage for this. Now, the only difference between the type 0 and type 1 deformity is that at this point, I'm going to place spreader grafts in there to address the internal nasal valves. For onlay grafting, again, I rely solely on auto grafts. There are a few ways to do this. The easiest way is either onlay grafting. I try not to utilize this because it can shift. If the soft tissue envelope heals significantly or is thin, you will see outlines of this. The bare dice cartilage, it's not a bad option. It is prone to shifting. They can sometimes palpate irregularities. My big fallback is the fascia wrap dice cartilage, and simply because the fascia has been shown to not only improve integration and reduce resorption of the dice cartilage, but this is a great, you'll never get perfect contouring of dice cartilage. And so this is a great way to sort of camouflage that. I do not recall off the top of my head a single case where I have regretted taking fascia. In fact, I think it's underutilized more than anything else. So this is, we're going to revisit my patient with the type 0 saddle nose deformity. Again, the goal is to restore the dorsal profile. Her main complaint was basically, look, I had my rhinoplasty in the early 90s. I don't like the scooped out. That's not something we strive for nowadays. We all looking for a more natural look. So using fascia and online grafting, we're able to restore a more natural appearance to the nose, and give her a more natural, more aesthetically pleasing, less done look to it. Revisiting my type 1 saddle nose deformity. Again, this is unfortunate. She just had an endonasal approach, and it looks like they just went right across here and didn't touch the tip. So here I harvested auricular cartilage. The last patient I did the same. Temporalis fascia. So I used some of the auricular cartilage for spreader grafts to address her functional component, then use the rest for dorsal onlay grafting to give her more of an aesthetically pleasing appearance, a little bit more of a natural look, but at the same time also allowing her to regain her nasal function. And this is the year to go back for those who are questioning how the aesthetic appearance of the anterior approach to harvesting auricular cartilage is. This was the same year I took it from the left ear. That's my go-to, simply because most of the time I'm operating with residents, and so it's easy to have them start closing the donor site while I'm working on the nose. But this is, you can see an appropriate and acceptable aesthetic outcome. The type 2 deformity, just to review at this point, we have internal nasal valve collapse like a type 1, but here we see tip depression, columellar retraction. So the structural support of the septum is compromised. Most of the time, I will say that this is not a static issue, 99% of the time, so it will only get worse. So I don't like to sit on these very long. At this point, the idea is to reestablish an L strut. The schematic shows that there's a columellar septal extension strut with extended spreader grafts. I usually will reinforce this along the septum all the way down to the nasal spine so that I know even if this does progress, I have structural support available. And I'll resuspend that tip on the extended the septocolumellar extension strut. So again, my type 2 saddle nose deformity. Again, I'm not very shy when I'm reconstructing the septum to use thicker grafts. I will caution on over thickness. In her case, she lost a lot of her septum, so I didn't mind doing this. You'd be surprised how much rigidity you can get from a relatively thin rib graft. So I wouldn't go that far, but we laid some fascia over it just because she had thinner skin for her background. And this is a 1-year post-op appearance. For the type 2 deformities, at this point, there's an extensive loss of septal support. This is a 2-staged approach, and I don't mean we stage the actual surgeries, but I approach the surgery, the single surgery, in 2 stages. The first one is I will reestablish the structural framework. And once I am confident that the structural framework is intact and the upper lats and the tip is resuspended on this new structural framework and is sturdy, then I'll work on dorsal contouring. So this is a 2-stage approach where I will reconstruct the L strut and suspend the upper lats. A lot of times, because of the contraction, you'll need a septocolumellar extension strut placed on your new L strut, and then I will resuspend the tip. Once this is in place, then I can focus in on my dorsal contouring. And so this is a 2-step process, one that you have to account for when you harvest cartilage so that you have an adequate amount of cartilage. And this is where temporalis fascia in my practice is almost completely utilized. So again, our type 3 saddle nose deformity This is actually her case. So again, dissecting past the muscle, underneath the breast. As you can see, the rib has been incised with electrocautery and harvested in a subperichondrial plane. You're going to get a good amount of stock that you'll need. And so again, we reconstructed the L strut and did dorsal onlay grafting. And now you can see there's no more blunting of the lateral aesthetic lines. And we've restored a more natural appearance to the nose by projecting her dorsum and tip in line with her facial features. Type 4 deformities, again, as we said, just to review, severe contraction of lining, but here the bony vault is also affected. So again, for these, I really rely on the calvareal bone graft. Special considerations in a saddle nose deformity also play into this, especially with these type 4 deformities, and I'll explain why. And of particular, what's commonly seen in the special considerations, at least in my practice, is the settings of GPA, in settings of infection, and in thick skin. In thick skin, it's probably more prominent, GPA, and then infection probably not as common as the other two. So to review, GPA, also formerly known as Wegener's, this is a granulomatous disease that targets the sinonasal tract. This really has a high predilection for the septal cartilage. So there's a high rate of saddle formation. Although rhinoplasty rates in this population are, the success rates are similar to the general population, there are higher resorption rates of L struts and number of grafts. We performed a systematic review a few years ago on this, and looking at all the case studies for reconstruction in the setting of GPA. The bone graft appeared to be more robust. So in these patients, I will upstage their classification when it comes to GPA. So what does that mean? If a patient with GPA comes to me with a saddle nose deformity and they have a type 2, I will classify them and treat them like a type 3. If they're a type 3, I will classify them and treat them like a type 4. And I think this is sort of me hedging my bets, because in these patients, there's always a risk of relapse or flaring of the disease postoperatively. This is because this is instigated by stressors. These patients, when they come to see me, most of the time they're referred by a rheumatologist, a few rheumatologists that I work with. If they haven't been seen by a rheumatologist, they will be seen by a rheumatologist, and I will not operate them until I am told by the rheumatologist that they're medically optimized in order to reduce the risk of a flaring of the disease in the postoperative period. So another patient of mine who has a clear type 3 saddle nose deformity. He's been a sufferer from GPA for a long time, has been afflicted with this disease. I worked with his rheumatologist to get him medically optimized and on a state where his disease is in remission. And again, because he's a type 3, I'm going to upstage him to a type 4. And so we're going to harvest a split calvareal bone graft. How I do this, I perform a long vertical incision across the hairline. I don't care how long it is because they're hair bearing most of the time, so it's not too much of an issue. My personal technique is I raise a pericranial flap that's medially based. I tuck it underneath the scalp, get access to the calvarium along the parietal bone, and I use powered instrumentation to produce a trough within the diploic layer and scallop this. And this is my technique. I use an angled dental saw to sort of get through most of it, just because in my hands it's less traumatic to the bone. And then as soon as there's a wisp of diploic layer between it, I can easily use that with a curved chisel and get that off. I prefer this just because I think it's less of a risk of fracturing the bone with a powered instrumentation. Other people prefer chisels. It's really what works in your hands. What I like about this donor site is that it's easily closed, but it's also easily camouflaged. So a lot of times what I'll do is take hydroxyapatite cement, cover the defect, and then with 3/0 Vicryl sutures, tack the medially based pericranial flap, bring it over the defect so that there's some vascularized tissue over the area. And I used to not do this, and eventually patients would ask why there's a depression in their skull. Since I've been utilizing this technique over the past 6-7 years, I have not had any complaints with donor site palpable irregularities. When you're using the split calvario bone graft in this setting, my technique, like everyone else's surgical practice, has evolved. Initially, I did not feel comfortable putting this graft in without fixating it. What I found were whatever type of fixation, K-wires or what have you, required additional surgery, either clinic procedure time or what have you, to remove the hardware afterwards. It was suggested to me by one of a senior surgeon who I just happened to run into at a conference that he said, I stopped doing that. I ended up taking the dorsum off and just having fresh bone to bone. And in 1 week, you'd be surprised how much osseous integration occurs. And I didn't really believe him until I tried it. So chiseling enough bone and putting fresh bone to fresh bone and taking the cast off, when you palpate the middle vault, there's no movement. It's pretty interesting to see this. I usually harvest a little extra bone when harvesting this for reconstructive techniques. I use this as a floating columellar strut, drill a few holes in it, and use prolines to resuspend the tip. It provides a little bit of extra rigidity for me and a little bit more predictability in terms of tip projection. But again, this can be placed right down onto the bone that you've just taken off with, I use a double-guarded chisel to chisel down the bone so that I have a smooth contour, and then that columellar strut to resuspend the tip. And it seems to be a fairly reproducible result. So this is 2 years out with his nasal profile. It's actually fairly, which was fairly consistent with the pictures he showed me before he started developing saddle nose deformity. So in patients with GPA, I'm more apt to upstage these patients, and I'm more apt to use the bone in the setting of GPA just because of GPA's predilection for nasal cartilage. Infection still happens. It's not very common, but you'd be surprised. And this is a team effort. So anyone with an infection, the two people I will almost always rely on is rheumatology and infectious diseases, because most of the time these infections that occur, when they occur, they're not the run-of-the-mill organisms or disease processes. And to highlight my point, another patient of mine who is a highly educated, very successful person, runs her own dance studio, was just floated around different hospitals with a disease process no one really could adequately pin down. And eventually was noted to have a long-standing infection, was treated with IV antibiotics, but by the time the damage was done, had a significant saddle nose deformity. And as you can see, that I just replaced her entire septum with rib cartilage. So her entire septum was gone. And now this is sort of a rarity, and I hate to diverge, but I just like this case because it was so interesting. Because while I was carving the rib, I couldn't help but notice it just looked like a septum. So I ended up trying it. It ended up working, but this is not my typical practice. And this is her 2 years out. This was great for her because she felt very subconscious. She's teaching young kids to dance, and obviously those of you with kids know kids love to ask questions. So this definitely was a win for her. Thick skin. I think this is one of the situations where the saddle nose deformity can be under-recognized. And I know that when I teach my residents in the clinic, I am very aware, obviously, in the setting of COVID, it's an interesting situation, but I don't operate on anyone unless I've had my hands not only on their nose, but up their nose. You really need to know where the structural support is. You want to minimize the amount of surprises you have while you're undertaking undertaking this complex reconstructive procedure. So thick skin, again, another patient of mine, just thought he needed a rhinoplasty or a little bit of support to his tip. But when you get past his nose, which it's very easy to see if someone would say, well, he's just got a Platyrrhine type nose. He doesn't really have a saddle nose. But his exam confirmed he had a saddle nose. He had a very short septum. It was compromised from trauma. The middle vault just sort of collapsed as soon as you wouldn't see it until you actually push down on it and put your fingers up there and realized that you know what, this guy had a significant saddle nose deformity. And you wouldn't see with looking at his nostrils or his external nasal valves that this would be an issue, but it was. This was one of the few cases that I run into where a lot of the cartilage was ossified. And this is actually the index case where I started requesting powered instrumentation just in case. And as you can see, this lateral aspect of the bone is actually completely ossified with very little cartilage. Again, you just have to be prepared. So I split this into both an L strut consisting of bone, the caudal strut, so the dorsal strut was bone, the caudal strut was cartilage, and use this to resuspend the dorsum and the upper lats. And this is a 4-year picture post-operatively. And again, the thick skin will hide a lot, so it becomes very difficult if you're not palpating the nose. So to conclude, it's a septal support loss. The septum plays so many roles in rhinoplasty and nasal dynamics that it's more often than not a septal support loss. But really the big thing here, if you really want reproducibility in your practice, the idea is to take a detailed and comprehensive plan and document very well. And this will actually determine how you approach your surgery. It makes it much easier, much more reproducible. And think of it as, both a method of support and camouflage. And I'd like to thank you for this opportunity to speak with all of you. And I'm happy to take any comments or questions.
Thank you very much, Dr. Azad. It's a great lecture. Everybody enjoyed it. We have Dr. Osama Al-Ani, who's here, works with me here in the hospital, and he has a question for you. Osama, you want to address Dr. Azad directly?
Okay. Hi, Dr. Azad. Thank you very much for this interesting talk. I would like to ask you about a case. A patient had septorhinoplasty, and she has a small perforation affecting the lower part of the nasal septum in the bony septum, about 1 by 2 centimeter along the floor. She wanted a revision septorhinoplasty because there is nasal obstruction, septal deviation, and still the nose externally bent to one side. So I would like your opinion. What do you think? Do you close the septal perforation initially, or you go ahead and do the septorhinoplasty and attempt the closure, or leave the perforation? Thank you.
So that's a very good question, and it's actually more common issue than you would think. So the questions that I would have in that setting, one, is the septal perforation symptomatic? If the septal perforation is not symptomatic, then I would go to size. And in my experience, any septal perforation greater than 2 centimeters has a very high risk of recurrence. It's very difficult to get a septal closure. However, the beauty of doing a revision case is a lot of times you've already mobilized the mucopericardial flap to expose the septum to perform the work. In revision cases, it's easier to harvest fascial grafts to help close the septum. Or at the septal perforation, that is. So when you have the septal perforation exposed, you've already mobilized the mucopericardial flaps. You can mobilize a little bit along the floor to get some, to be able to close it with less tension. you also have the ability to use fascial as a transposition graft across the perforation. So in these instances, I inform the patient that there's a perforation. I tell them that I'd be more than willing to try to close it and try to perform rhinoplasty, and just let them know that there's an increased risk of worsening of the perforation. In those cases, I would probably say if I believe that there's any compromise, not significant, but any compromise to the septum, I probably will take some rib and even use a little bit of even thin extended spreader grafts just to reinforce the septum, so that if for any reason the septal perforation grows, I know at least there's a lower risk of this affecting my ultimate saddle or my ultimate septal support. So if you can, definitely address it at the time, because you have grafts available to use. I wouldn't do it before and then come back, because you're never going to have the exposure you have with an open rhinoplasty. You don't want to open the entire nose and then go back in and have to open it again. So it's probably better to get it all done in one shot.
Thank you. If there's anybody who has any more questions, if you could raise your hand, I will open up the microphone. But we're coming to the end of our time, so I think this would be the end of the session. Thank you again, Dr. Azat. Very nice talk and very informative lecture. I have to tell you, I don't know much about this stuff. I'm more into the otology stuff. I'm more into the sinus stuff. But thank you again.
I really don't. I was just informed last month that there was something inside the external ear. So.
Do you speak Arabic, by the way?
بكلم عربي.
Oh yeah, no, all right, well, okay, thank you. So thank you all, and we really appreciate having you with us. I'm just going to share with you the talks for the next few days, and let you take a look at that. Thank you again. Have a nice evening.